أياما معدودات فمن كان منكم مريضا أو على سفر فعدة من أيام أخر وعلى الذين يطيقونه فدية طعام مسكين فمن تطوع خيرا فهو خير له وأن تصوموا خير لكم إن كنتم تعلمون. شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصم ومن كان مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر ولتكملوا العدة ولتكبروا الله على ما هداكم ولعلكم تشكرون. صدق الله العظيم. الفاتحة. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين نبينا محمد وعلى آله وصحبه أجمعين. اللهم إنا نسألك خير ما في هذا اليوم فتحه ونوره وبركته وهداه ونعوذ بك من شر ما فيه وما بعده يا أكرم الأكرمين. اللهم افتح لنا بالخير واختم لنا بالخير واجعل عواقب أمورنا بالخير بيدك الخير والعافية إنك على كل شيء قدير. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين.
Jazakallah Shaykh Said for the recital. So we'll kick off this morning session with 3 talks. We look back to very prominent individuals. One is Dr. Khalid Dalsay, who is a psychiatrist, and Tasleem, who practices family medicine. Tasleem Ras, she's professor of family medicine. I'll give you them 15 minutes in a minute. Just a few housekeeping. The first thing is we have the papers presented back to back. So in other words, we need the question answers at the end. In other words, that's able to release paper first, and then Khalid will present these, and then back again to the same. Second housekeeping very quickly. If anyone wants to present their badge to underprivileged children, you can leave it your bag at reception. Okay, so if anyone wants to do so, feel free to make your badge some peace. The second thing is CBD points, please sign. Okay, so at the registration desk, you'll get a list and please sign so you can get the points. Okay. Third thing is just a reminder from Kanchika, please visit the art exhibition stand, which is at the entrance to the exhibition hall. Okay, so you want some more support in that way. All right. So, without further ado, before Tasleem Plus is Associate Professor of Family Medicine at UCT. And in addition, he has a special PhD in health science and education. He's published widely, supervised master and doctoral research, co-authored a textbook on family medicine, and assistant editor at the PLOS, which is Global Public Health Journal. He teaches clinical medicine, research methods, and clinical ethics to postgraduate students. Tasleem is the current Vice President of the South African Academy of Family Physicians. He also reminds me that he is married to one wife. Okay, he's got 5 children, he's got 2 kittens, 2 cats, and an Alsatian, or German Shepherd, I think it's called. Okay, and he loves soccer, but he's rather depressed this morning because his favorite team lost yesterday. Okay, to their rival, Manchester. Okay, I didn't catch up with that. It's Manchester Derby. Yeah, it is a disaster. Who won? Manchester City. Yeah, but they played by goals. So, Tasleem.
Assalamu alaikum wa rahmatullahi wa barakatuh. So this talk was quite an interesting genesis. About the end of last year, some colleagues and I were sitting down and we thought, let's look at the South African literature around Ramadan fasting. And we looked, and we looked, and the more we looked, the less we could find. And to my amazement and astonishment, there wasn't a single published article in any of the South African peer-reviewed journals that deals with Ramadan fasting. Other types of fasting, yes, intermittent fasting, etc., but not Ramadan fasting. And we thought, this is quite an interesting thing, and then we spoke with some non-Muslim colleagues, and it turns out that the availability of guidance to doctors in general around what constitutes good advice to Muslim patients who are fasting is to non-Muslims. So within the IMA we have guidance, but outside of the IMA the guidance doesn't exist. So there's a need for us to propagate this message of what constitutes good practice in Ramadan fasting beyond our community. Hence, in the beginning of this year, we published this paper, and I think, I stand corrected, this is the first time that we now have a publication in a DOIC accredited journal in the South African context on Ramadan fasting. I hope it's a conversation starter, and I hope that it leads to many more publications from within our Muslim medical community around some of the aspects of Islamic practices. That's available in the South African Family Practice Journal, which is an open access journal available online. I have to give credit, apologies to my co-authors, which is Dr. Ashika Holdman and Dr. Diane Matthews, who are colleagues at the University of Cape Town. They teach in the undergraduate space. So I'm not going to go through this slide in much detail because it's really an introductory to non-Muslim colleagues. I gave this talk in an online in a webinar a few months ago where the majority of the colleagues were not Muslim, and so we needed to go through some basic rules about what constitutes Ramadan fasting. I think it's important for us just to understand the scale of the issue. Globally, we're about 1/4 of the world's population. In South Africa, we are close to half of the in Africa, close to half of the African population, 1.5 to 2% in South Africa. So while it seems as if we're a tiny minority in South Africa, our reach in Africa is immense. And so the contribution, the responsibility that we carry to popularize this type of discourse within Islamic medical communities is quite important. And so our key question when we approached this topic was, what's the current state of the literature in relation to the effects of fasting on people living with non-communicable diseases? And we used a narrative approach. It's because it was the easiest, given the paucity of data that we were able to find. I'll just do a brief description of our methods. We didn't do a scoping review or a systematic review. For those that know, those are the formal types of literature reviews. We did a narrative review, which gives us a little bit more leeway in terms of how we use the data. We searched the online databases, PubMed, Sabernet, Scielo, Google Scholar. And so you can see that we cast our net pretty widely. And then we expanded our search terms to include Ramadan fasting, with alternative spellings of Ramadan, health impact, health. We looked for some clinical guidelines. The original article, the article that we published, had some mental health issues it also involved, but I'm not going to speak to that this afternoon. I'll leave that to Khalid, the expert. We used elderly, physiology, diabetes, mellitus, and metabolic disease. So you can see that we cast our net pretty widely. How we then decided to use which articles was we looked at titles, and for those titles that we included, we reviewed the abstract. So we looked at the abstract to see does it speak to our needs. And then we did a more detailed reading of those articles that we thought the abstract spoke to our question. We read those iteratively, so we read those, each of us read them. And we appraised their methodology just to give us a sense of how rigorous, what's the level, what's the quality of the findings presented in those papers. And that's important when you're doing a review, because you want to be able to say at the end of the review that I think this is what the literature is saying with certainty, and so part of that statement of certainty speaks to the methodology of how the paper was constructed. So I'm going to be unfolding just a few of the key issues that we read around, and there's a full list of references at the end. I know that the IMA is making these talks available, so anybody wants to go and read up in more detail on any of the papers that are quoted, please go ahead and do so. The key input physiologically is that there's a change in eating habits. We know that. And diet, and I think it's important to say that because we don't eat the same outside of Ramadan as we eat inside of Ramadan. And quite interestingly, there were quite a few observational studies across predominantly the Muslim world, but extending from the Arab world into the non-Arab Muslim world, which showed a consistent change in dietary patterns. So not just the times in which we eat, but the quality of the food that we consume. In many instances, more calories are being consumed in Ramadan, much more fatty foods, and for some reason there seems to be a decrease in protein consumption in Ramadan, which I find quite interesting. And those are all culturally driven. So these are not eating patterns which are driven by scientific guidelines. These are all kind of culturally determined patterns. And then the second thing, which more and more the literature speaks about, the impact of sleep on chronic disease management, that there's a substantive change in sleeping patterns during Ramadan. We all know this. We sleep later, we get up earlier. Some of us get up right in the middle of the night. Tahajjud becomes a prominent feature of our daily practice. And then we have the daytime naps, which might not be a feature of what we're doing outside of Ramadan. So the net effect of all of those inputs is that dehydration is something which is unique to Ramadan fasting. And if you look at the literature on this, intermittent fasting, for example, which has become so popular in terms of a disease-modifying modality, doesn't include any type of dehydration. So the amount of water that people who are doing intermittent fasting are able to consume is unlimited. So I think that's an important consideration when we're speaking to our patients about what constitutes the differences between Ramadan. And for me, when I think about it, that's probably the single physiologically most important difference between the two. So we can't equate Ramadan fasting with intermittent fasting purely because of the lack of hydration input, which results in increased urine osmolality. And in healthy people, we'll speak a little bit later about those that are not healthy, it corrects quite easily. So the research is quite clear about that. There's improved fasting glucose levels in terms of during the month of Ramadan, which rapidly returns to pre-Ramadan levels within 2 to 3 weeks post-Ramadan, as the people get back into their eating patterns. Lipid profiles improve quite considerably. And the papers that I've read indicates that change, that improvement in lipid profile is sustained for a few weeks after the month of Ramadan. We're not sure, so there's no literature that says what happens if we're doing the Monday, Thursday fast continuously and what's the impact on that. So there's a question in my mind in terms of, yes, there's a positive impact from just fasting in Ramadan, but what happens when that type of fasting is ongoing, Monday, Thursday, middle of the month, etc. And I'm raising this at this point because it's a gap in the research. And so it's a call to us to ask, can we start doing that type of work to fill in those research gaps? And the last point in terms of the effects I want to make is about the disrupted circadian rhythm, which we now know impacts on cortisol metabolism, impacts insulin secretion, and hence glucose control. But that's not the only thing. We also know that cortisol has an impact on mental health, on immune function, and on so many other parts of our physiology. So fasting has a very, very significant impact on our metabolic life on multiple levels. I think that's the key take-home message. We need to think about how we're engaging with all of these changes as we counsel our patients. So let's talk about diabetes. This is not the commonest chronic condition, but probably one of the most significant, with probably the highest target organ damage rate of all the chronic conditions. In Ramadan fasting, there's a high risk of complications. There's been quite a bit of work around diabetes internationally, and I really like this group that I found when we did the literature, which is the International Diabetes Federation, and there's a subgroup called the Diabetes in Ramadan Rating Group. And they've gone and looked at extensive literature around diabetes and come up with this. It's projecting, okay. There's risk factors for adverse outcomes, and I think this is such an important thing that we can use when we counsel patients. So I can't see it so easily, I'm going to read it off of the slide. I think obviously type 1 diabetes, people that are on insulin, I think as soon as we have insulin and fasting in the same sentence, then we need to have red flags going off. And many patients on insulin, we should be counseling not to fast. Someone that's been living with diabetes for more than 10 years, so that's so many of our patients. Whether there's lots of hypoglycemic episodes, uncontrolled HbA1c. How often do we see people with HbA1cs of 10, 10.5, 11, and we say, it's okay, it's not 14. But we need to be strict about HbA1c control. And just interestingly, another paper that we published around COVID outcomes and diabetes indicates that when your HbA1c is above 9.5, your risk of adverse outcomes with COVID is much worse. So tight control on day-to-day diabetes has multiple good effects, including improved outcomes for those people that want to fast. I already mentioned insulin, poor self-monitoring of glucose control. All chronic conditions need the patient to be intimately involved in their healthcare, and that intimate involvement is not only popping pills and adherence to the doctor's prescription. If there's been any type of instability in the last 3 months leading up to Ramadan, any type of target organ damage. It says the macrovascular disease, but I would argue any type of target organ damage. Frailty score explains itself, and cognitive impairment explains itself. Renal impairment we'll talk about, and I think we're all on the same boat when it comes to pregnancy. So I don't expect you to remember, but I do ask that you remember the Diabetes in Ramadan writing group from the International Diabetes Federation. Open access, online, you can all access all of that and incorporate that into your practices. Ashraf, I'm going to ask you just to warn me then, because I'm getting carried away. Okay, so what does the IVF DAR guidelines state about how to structure your diabetes care for your patients? The first is about 6 to 8 weeks. So your care for the patient, as I said, the care for the patient is continuous. So you're looking at tight diabetes control. You want to monitor impact on the target organs. You don't want to enter Ramadan and be surprised by a low GFR. You want to know what your patient's renal functions are like 2 months before Ramadan. So your Muharram package to your diabetic patient should be, here's the plan for this year. So there's an initial pre-Ramadan visit about 6 to 8 weeks before, where there's knowledge sharing, risk assessment, therapeutic optimization geared towards the patient making an informed decision. At the end of the day, you can tell your patient, I think you should fast or I think you should not fast. You know that 83-year-old woman who's been fasting for the last 60 odd years, 70, 80 years, is going to make her own mind up. But your job, our job, is to make sure that when she makes her own mind up, she makes it with as much information at hand as possible. So that's the purpose of this 6 to 8 week pre-Ramadan visit. During Ramadan, there needs to be self-monitoring, not coming to see me on a monthly basis, on a weekly basis, self-monitoring. The patient takes full ownership of their own health with an understanding of what the red flags are and close availability of the health professional. And then the third big recommendation coming out of these guidelines is that there's a post-Ramadan assessment, a kind of a wrapping up, a reflection, and what's the way forward. And what we then do is we customize it according to the patient's particular risk category. Now there's a few therapeutic considerations that the guideline highlights. The guideline flags these for us. The first is hypoglycemia is the commonest complication, particularly on those patients that are on insulin and on sulfonylureas. Interestingly, which I found this interesting, the data doesn't indicate that metformin is implicated in fasting-related complications, except that you must make a dose adjustment, obviously, if you're sitting on a 3 times a day dose to a twice a day dose. And then the SGLT2 inhibitors seem to be safe. There is some preliminary evidence in those patients that are fasting. It's preliminary, but just some caveats. Those on SGLT2 inhibitors tend to be elderly, they tend to be on polypharmacy, they tend to have comorbidities, so proceed with caution. Just those 3 factors already elevate the risk category. So that's diabetes, we often know it. And then we move to hypertension, which is by far the commonest. In South Africa, we're looking at the prevalence rate of a conservative prevalence rate of 30% of our adult population with essential hypertension, and the more realistic prevalence rate is in the low 40%. So almost 1 in 2 adults in South Africa is sitting with diabetes, and about 1/4 of them, maybe more, are undiagnosed. So this is a very, very important condition in our population. I found 3 systematic reviews that Ramadan had a positive clinical effect with a sustained effect for a few weeks after fasting has stopped. Once again, I was disappointed to find that the Nafil fasting wasn't included in any of these studies, but I think it's something that we need to be thinking about. So if there's this positive, sustained effect from 29 or 30 days of continuous daily fasting, what are the implications for us extending that beyond? So the therapeutic potential of fasting is already established in the 2 commonest and most significant chronic conditions. But when that person had comorbid renal impairment, there was no impact on the blood pressure control. So point about this is the renal impairment is starting to emerge as a key red flag for us to consider. Longer term implications is that low quality studies with weak evidence to show longer term impact on cardiovascular health. So a lot of the research that I've came across is not great quality. No reports of adverse incidents of antihypertensive agents during fasting, because I could only find 1 small observational study. And my biggest concern when we were looking for this was the effect of diabetics. A lot of our patients just decided, I'm not taking the water tablet during Ramadan. And so I couldn't really find, so it was a little bit disappointing. And interestingly, the longer term effects of particularly stroke, hypertensive stroke, there was no difference in prevalence, which is understandable because Ramadan is only 1 month. And so, 1 month intervention is too short to have a long-term impact on outcomes. This for me is the big R in Ramadan fasting and chronic disease. Where the GFR is less than 60 mL per minute, we're sitting with established chronic renal disease. Short-term dehydration, even for 8 to 10 hours, impacts on renal tubular health. It causes damage. And so patients with EGFR less than 60, the guideline says should not be, or the literature that I've read says should not fast. They're putting themselves at higher risk. And for those who are insisting, which we know many, because at the GFR of 50, you still feel okay. You know, you're a 65-year-old person, you've had hypertension, there's not always great control. Your GFR has been slipping slowly, it's sitting at 55, 60, 50. You still feel good. You can do most things. And now the doctor says, you know, I don't think you should fast. And I think what you're talking about. So we need to then be pushing this morning and evening hydration. It doesn't fully reverse the renal tubular damage, but it does mitigate some of the effects. And this was also surprising for me, despite talking to colleagues and my own clinical experience, there was no evidence for increased incidence of renal colic due to renal calculi during Ramadan. I don't know. I still don't believe that finding. Post-renal transplant, but this is quite interesting, is that a single observational study, so there's only one low-quality study, suggests that if renal function is stabilized for more than 6 months, then fasting is safe. So when they're out of that danger period, they've stabilized, but the renal function itself needs to be stabilized for 6 months. And then puasa malika. No evidence specifically in relation to safety of Ramadan fasting was found in relation to cancer. But I think it's almost intuitive. You know, you're going to advise your patients based on the staging of their disease, the complexity of their disease, what type of treatment they're getting. There's some evidence which suggests that ketogenic and calorie-restricted diets may slow the growth of the cancer and improves chemotherapy outcomes, but maybe not for this talk, but just something to think about. And then what I came up with in terms of what the Islamic scholars are saying around fasting is that there's unanimous opinion that not mandatory for these patients. This is an ongoing, this is my second last slide, an ongoing question that we have. So in South Africa, about close to 10% of our population is over the age of 60 years. That's from the 2022 data. Some specific issues relating to aging is we have physiological aging, which means muscle mass goes down, there's organ function which is in decline, cardiac output is declining, and we have CNS deterioration. With muscle mass, there's a real issue in terms of how people use hydration. Cognitive decline is an issue, and then the issue of polypharmacy. So there are some specific issues relating to the elderly population that we must be fully aware of. And for those with existing disease, there's a transient improvement in lipid and glycemic control. Renal function declines in Ramadan, unfortunately, and that's because of the altered water metabolism that whether we want to or not, that is a function of aging. There's improvements in mental health, particularly around depressive and anxiety symptoms, but Khalid will speak more to that. I spoke to the BP improvements, and the caveat there is BP improvement, but not in those with pre-existing renal disease. And then, very importantly, something that we don't frequently think about is that the risk of falls. And there was an interesting Indonesian study that showed that the risk of falls were elevated from the second week of Ramadan onwards, persisted until 3 weeks after Ramadan. So there's balance issues in the elderly that I didn't really think about initially. So, once again written for a non-Muslim audience, but I think we all agree that there's psycho-social, spiritual significance for us as Muslim practitioners. The biomedical perspective needs to be expanded to incorporate the psycho-social, spiritual perspectives. I think there's a lot of work for us as an Islamic medical community in terms of the scientific rigor and publishing outside of our own circles to advise our colleagues who are treating Muslim patients and to give them good advice. We need to be very wary of the special vulnerable groups within our community. And I, as an academic, I'm always looking for opportunities for research. And I think I was just talking to Ashraf before, we don't have a special interest group for research within the IMA. I think these are the types of things that I'd like to see emanating from within the IMA. Nobody else can do this work. Nobody else has the motivation to do it. I think this is something that we can look at. Jazakumullah.